Good afternoon, everyone, and welcome to the third installment of the Nurse Staffing Task Force Project Echo series. Session 3 is titled Innovative Care Delivery in Nursing, a Paradigm Shift in Healthcare, and will be presented by Dr. Katie Boston-Leary and Dr. Kiersten Henry. Throughout the series, we will hear from members of the Nurse Staffing Task Force as they share recommendations and actions to tackle the nurse staffing crisis. I will be your host for the series. My name is Nicole Anselm, and I am a senior policy advisor within nursing programs at the American Nurses Association. This is a 5-part interactive series featuring content developed and presented by members of the task force. Our goal is to engage nurses in discussions around actionable steps towards tackling the nurse staffing crisis. You will earn 1.5 CNE credits for today's session. In the first part of the session, the imperative is introduced and information and context on how it relates to nurse staffing are provided. This part of the session will be recorded and will be made available on demand at nursingworld.org. After the presentation, we will engage in discussions focused on actions nurses and nurse leaders can take towards implementing the imperative. We encourage you to participate in these peer discussions. To briefly review what we learned about the think tank and task force in session 1, the think tank recommendations were published in April 2022, and the task force recommendations were published a year later in May 2023. The think tank recommendations focus on organizational changes that affect nursing practice. This includes recommendations on work schedule flexibility, the stress injury continuum, and total compensation for nurses. The task force recommendations are focused more on policy that impacts the nursing profession. These recommendations center around staffing standards, regulatory efficiency, and the value of nursing. However, what the two documents have in common is that they both address recommendations concerning the healthy work environment, innovative care delivery models, and diversity, equity, and inclusion. Last week, we discussed how recognizing the value of nurses' unique contribution relates to the staffing crisis. Today, Dr. Boston-Leary and Dr. Henry will look at ways organizations can innovate the way nurses provide nursing care to patients. This aligns with the next imperative of the Nurse Staffing Task Force: innovate the models of care delivery. Dr. Kiersten Henry is a critical care nurse practitioner and chief advanced practice provider at MedStar Montgomery Medical Center. She previously served as director of the American Association of Critical Care Nurses and served on the Nurse Staffing Think Tank and on the Nurse Staffing Task Force as a nurse advisor. She has co-authored on topics including nurse staffing and resilience during the COVID-19 surge. Dr. Henry has lectured locally and nationally on the role of advanced practice registered nurses in promoting a healthy work environment. Dr. Katie Boston-Leary is the Director of Nursing Programs at the American Nurses Association, overseeing the Nursing Practice and Work Environment Division, as well as Healthy Nurse, Healthy Nation. She is an adjunct professor at the University of Maryland School of Nursing. Dr. Boston-Leary serves as staff on the National Commission to Address Racism in Nursing and is also part of the National Academy of Science and Medicine's National Plan to Address Clinician Well-Being. She was the ANA representative for the Nurse Staffing Think Tank and Task Force. Her recent research was a qualitative study on nurses' perception of power dynamics in the hospital setting. She has written and co-authored numerous articles on staffing, diversity, and leadership. And now I will turn it over to our first speaker, Dr. Kiersten Henry.
Hi, everyone. Thank you so much for joining us today. I won't say this afternoon because I see we have people in England, so it's evening for some of you. Thank you all for joining us. It's really exciting to be at the point in this journey where we're taking all this work and talking about what's next. How do we all move it forward? And to see over 300 of you here participating in this really is exciting. So thank you for your time. Our objectives today are really to focus on innovative care delivery models, and we're going to talk about how we evaluate care delivery models, particularly innovative care delivery models, including outcomes for patients and nurses, talking about how nurses can contribute to processes that look at our existing practices and compare them with current guidelines, identify opportunities for reducing the physical workload for our staff and their cognitive overload, and identify 3 ways in which technology-based innovations affect a nurse's workload in the unit or organization in which they work. So it's always good to sort of ground ourselves in definitions. And when we talk about nursing care delivery models, they're also called care delivery systems or patient care delivery models. And they detail the way that task assignments, responsibility, authority are structured to accomplish patient care. So really, what is the structure of our patient care delivery? There are 4 classic delivery models, the first being and when I think of these, I think of sort of those long-standing, almost, based in nursing theory, care delivery models. So as we move forward, we'll talk about the fact that, we're not always talking about developing a completely new care delivery model, but adapting components of care delivery, to start making those meaningful changes. But our classic care delivery models include total patient care, where the nurse is responsible for all of the care for a particular patient. Functional nursing, which is really task-based care. So different nurses are responsible for different tasks for each patient. Team nursing, which we really saw kind of a rebirth during the pandemic, where a nurse is teamed with a group of nurses to direct the care of a group of patients, possibly with nursing technicians or other team members, so that you can sort of leverage the skills and expertise of each person involved in the team. And then primary nursing, which is relationship-based care, where there's a focus on one nurse being responsible for the patient throughout their patient care journey in the hospital. So we're going to launch a poll here in a moment to ask you a question. You'll have a couple of these throughout the course of this talk, because we want to kind of get a sense for what you all are experiencing. And the question is, do you believe your organization's care delivery models need to be improved and or changed? And you'll have a moment to answer that. But when we talk about care delivery models, we also call them systems of care delivery or patient care delivery models. And again, we talked about, they sort of detail the way that tasks and responsibilities are delegated. When we talk about redesigning our delivery model, as I said before, I think that can sound daunting, that we're talking about redesigning, and do we have to develop a new theory or philosophy of how we provide care? But what we really need to focus on is innovation, making those small rapid cycle changes, implementing, assessing those changes, and seeing what helps us to get to a better patient-centered model of care. So innovative doesn't have to mean complex. And I think that's a really important grounding point for today, that it doesn't mean we have to entirely rewrite a theory or a model, but we need to start looking at small ways to innovate. So we'll go ahead and launch the answer, I think. So 66% of you said, this is pretty, not surprising, but pretty telling. 66% of you said your organization's care delivery models need to be improved and or changed. 6% said no, and 28% of you said maybe. So I think that's pretty telling. And when we have our breakout sessions, it would be very interesting to hear from the 6% of you who feel like your care delivery model is really working effectively for your patients, because I'm sure there's lots of us who would like to learn from you. So the Studer Group published a study in 2023 with ANA, with about 3,500 nurses, and they asked nurses, including acute care leaders and acute care frontline staff, do you feel that your organization's current care delivery models need to be improved? And interestingly, our poll, I think I just said 66% of you said yes. 72% of leaders and 67% of frontline nurses in acute care said that their care delivery model needed to be improved, and only 13% said no. So I think the responses here today are very much in line with what was seen in a survey of 3,500 nurses and leaders. This is something that's really interesting to me in the American Association of Critical Care Nurses. Healthy work environments work is really near and dear to my heart because it's really foundational and has been shown to, having a healthy work environment increases patient safety, increases nurse satisfaction and retention. So there's a lot of reasons that that's important. But one of the things in their periodic survey of work environments that they asked nurses is, how would you rate the quality of care in your unit and your organization? And in the survey in 2018, which obviously was before the pandemic, 23.5% of nurses related the quality of care in their organization as excellent, but in their unit, 43.7% said the quality of care was excellent. In 2021, only 15.7% of nurses rated the quality of care in their organization as excellent, and just under 30% said the quality of care in their unit was excellent. So what I think really, to me, why this is so important and this data is so telling about where we are is nurses are not feeling satisfied in the care that they're able to provide in the current models of care delivery. So it's not, obviously patient safety and patient satisfaction are a top priority, but we as a body of nurses also are not feeling that we're making our optimal contribution in providing patient care. And did I just skip? I did skip a polling question. Sorry, I'm going to go back. Can we go ahead and run the polling question? Thank you so much. So if you have not made any changes to your care delivery models in your organization, what are your top reasons? So pick one reason here that's a barrier for you. And then again, we have the benefit of comparing this to the Studer study, the Studer and ANA study, just to see how what you all are experiencing reflects in comparison to that. And again, I bet it will be quite similar. Give a moment for everybody to answer. Whenever we're ready, we can. Okay, so 34% said unstable workforce, 17% said leadership resistance, 10% current models are sufficient, 15% financial constraints, and 24% organizational barriers. So it looks like organizational barriers and unstable workforce were our top responses. So when we compare that to what was found in the study that was published in 2023, you can see 26% listed unstable workforce as their reason. So the same, I think we had 17% said leadership resistance, and it's 19% here. And organizational barriers were a little lower at 13%. But again, very similar reasons for not being able to really make change in care delivery models. So when we think about innovative care delivery models, we've sort of talked about what's not working, why it's not working. So now let's start to think about, how can we make it work better? So our operational definition of innovative care delivery models are models that combine high tech and high touch or high quality care with an inclusive and integrated approach for patient and nurse satisfaction, reduction of pain points, and improved outcomes. And again, as I mentioned earlier, and I think this is really important because I think when we look at the body of work around staffing that we've done with the think tank and the task force, when you look at it in its entirety, it can be it can be overwhelming to think about implementing all those changes, but I really encourage people to look at it as a whole and then to pick those first couple of things that they can start to work on. And I think the same thing is true with our care delivery models. We don't have to completely redesign. We should focus on changing specific components. And then we're also going to be able to make those rapid cycle improvements to those components and be able to assess specifically, is that improvement making a difference, rather than overhauling and not really having a handle on what changes were most effective. So we want to focus on changing specific components and evaluate the impact of those changes. And one of the things that we talked about during the think tank and task force a lot is a tribrid care delivery system. And if you've not heard that phrase before, I'm going to explain it in a minute. But you know, when we all hear hybrid, this is what we think of probably. But using the definition, that's one of the dictionary definitions, it's a thing made by combining two different elements. So then tribrid care delivery is a thing made by combining three different elements. And those three different elements are on-site care delivery, IT integration, and virtual or remote care for the patient. So we're really taking that high touch bedside nursing care delivery, we're taking the IT systems that we have, and we're leveraging telemedicine to lead to optimal patient outcomes, optimal nurse satisfaction. So tribrid care delivery models, again, are those models that combine high tech and high touch for optimal, high quality patient care that will increase patient satisfaction, increase nurse satisfaction, and decrease practice pain points and workload. So in a lot of instances, we have components of this in place, but then it's about streamlining and refining that system so those three components work most optimally together. And another survey question from the Studer ANA study asked about virtual nursing. And since the pandemic, has your organization implemented or considered implementing virtual nursing? And this was really interesting. And Dr. Boston-Leary and I were talking about this as we prepared for this talk, that 33% of leaders said, yes, we've considered implementing or we've implemented, and 13% of frontline staff said yes. And it makes sense that not everything that gets talked about in a meeting, if it doesn't get implemented or in a, in an idea generating session, doesn't necessarily get shared with staff. So it just sort of raised the question, I think, how can we communicate what we're considering? How can we leverage? And one of the recommendations of the task force was really having nurses engaged at these, or frontline nurses engaged at the level of decision making, not only for their contributions, which are valuable, but also for the ability to then disseminate information to other staff. So I think this really shows that there's an opportunity to engage our frontline staff in looking at these ideas and just in awareness of what's being considered and maybe why things are being implemented versus other strategies. And with that, I'm going to turn things over to my colleague, Dr. Katie Boston-Leary, to talk about some exemplars and also some other thoughts on implementing innovative care delivery models.
Thank you, Dr. Henry. Dr. Henry and I both presented on the think tank recommendations at Magnet last year. So it's really nice to it's always good to work with her. So I am going to carry us through to the end of this presentation, but I'm going to start with exemplars and some of what we're seeing in the field that you can learn from or you can relate to based on where you are in your organization for reinventing or innovating your care delivery models. Let's see if I get my arrows to work here. Yes. Okay. Oh, I hit it too many times. Go back. I think there's a delay on my end, so I'll be patient and not hit it more than once. But the example that I wanted to show you in the image before this is of Syl Trepanier, who's at Providence, St. Joseph's Health, and he has a model that he's implemented where they are using virtual care in addition to supplement or augment their teams that are on the ground with the tribrid model that Kiersten just mentioned. What's great about his model, and I'll go to the next slide so you can kind of see some of the outcomes from what he's implemented. And right now it's a pilot, but seems to be going well. With what he's done with this change that he's done with these teams, and he's also added LPNs to his care delivery model. He's seen significant improvement in all the metrics that they set up to measure success. They've seen a decrease in length of stay, a nearly 40% decrease in turnover, a near zero vacancy rate for ancillary staff, and we know they're important too because they help us with what we do. And annual expected cost avoidance of $500,000 for the pilot unit that they're utilizing or using this model on. So in the resources that you get for this session, you'll get the article that gives you a lot more detail. And he really outlines how he set up these teams and how he really looked at not only how we can achieve some patient outcomes, but he also looked at nurse satisfaction as well, which is what we're saying, and he leveraged technology. So that is a tribrid model that we're talking about, and he's seeing some really good success just from a pilot on one unit at this point. So wanted to share that story with you. And then another colleague of mine that some of you may know, Dr. Richard Cumming, he's at Christiana Care in Delaware, and they've implemented Moxie robots. And for those of you that are not aware of this technology, this is the hunter and gatherer. This is a fetcher for nurses. And it's also a patient satisfier as well. And I'll share a personal story where my husband was admitted to his hospital. And I was in the main floor going to visit my husband in his room. And here comes this robot behind me, which was very exciting to see because I've only seen it in pictures. And you can see the excitement on that level with people going by, just really excited about the technology, seeing that it's there just from aesthetics perspective, but and it was totally unguided. And when you talk to some of the nurses, they will say that not that this technology is the answer to everything, and it has helped with helping with getting supplies and things like that, but they also really appreciate the investment that's being made to help with one major pain point that nurses are having in the institution. And I believe they've implemented this, a number of these in the institution. And I know there's as a best practice where a number of hospitals are contacting them to learn more about this technology. In terms of data, to understand how it's having an impact, they are tracking how many deliveries this technology is taking on compared to what would be done by humans. And you wonder, okay, well, what does it mean cost-wise? But remember, we're also in a place now where we're struggling to retain and recruit ancillary staff, particularly folks that are in that space that help with a lot of the stuff that nurses are now absorbing in terms of retrieving supplies, making runs to the lab and things like that. So it's really served that purpose. And they're seeing that the adoption rate is going up over time, where they're seeing a lot more people trusting the technology and a willingness to really see what else this technology can do. So another study that I like to share with you is a study that we did with, ANA did with McKinsey. And McKinsey and Company does a lot of healthcare intelligence work and assessments and understanding, best practices, and also surveying the landscape in terms of what's happening in healthcare and in other industries. So we did a time allocation study with McKinsey to understand how nurses use their time, how they would like to use their time, and also what they ideally could delegate and what could be more tech enabled. One part of the study was really about how, which is what we connected to with the American Nurses Foundation study that we just released. We wanted to understand how nurses felt about their current workload. And from the study that we just did, we saw that 43% of nurses indicated that they had marginal or poor control of their workload.
Oh,
Um, why is that concerning? People would say, well, this is the nature of the beast, right? This is what we signed up for, but not necessarily so, because we want to be able to have control over the work that we do and how much we do and when we do it. So that's why this is important. And this ties directly to working the healthy work environment, which is what you heard a couple of with our first session. We need to make sure that we set up our environments for nurses to have more control and to be able to manage their workload in a better way. The same study also indicated that 41% of nurses find their work area intense or hectic. Only 3% found that it was calm. And, I'm sure this is not necessarily in the acute care setting or where patient care is being delivered, but this is also concerning where you think about the workload piece. And when we talk about workload, we're not just talking about physical workload. It's psychological, it's emotional, and it's cognitive as well. So we need to really make sure that we understand how nurses are perceiving their work environments and the work that they're doing and how they can have control over it. But when going back to the McKinsey study, we really wanted to also understand how nurses are spending their time and what they'll like to do more of and less of. And to really help with driving them working at the top of their license, to help address a number of the concerns that they've had over being taken away from patient care. So you can see currently a number of nurses that respond to the survey, and the sample size for the survey was about 300 nurses, but we reached saturation at around 200. And 54% of nurses felt 54% of time was spent on direct patient care, with 4% being spent on growth and development, and 2% being spent on RN to RN teaching, and you see it go on and on. But we also saw that nurses also shared what they spent a lot of their time doing. But when you look at the ideal, and we do feel that this is conservatively stated because nurses are accepting that, this is what they'll have to do. They'll have to spend a lot more time, even though it's not ideal, they're spending a lot more time gathering supplies. But when you look at some of the other pieces in terms of what nurses like to do less of, and that's where you spend time looking at charting, documentation, which is a major issue for us. And this has been a concern with the clinician, the National Wellbeing Action Plan, where we need to look at our EHRs and whether they're really working for us. Some people will say that what's been set up with our EHRs is one of the broken promises, the biggest broken promises in healthcare with nurses. And technology has not necessarily been kind to nurses. So how do we look at documentation? How can we look at hunting and gathering, which is really the gathering of supplies, information, and people? We know that there's a struggle with understanding who to call to when you have a critical result. Do I call the attending or do I call the specialist? So who is the attending anyway? Support activities as well. That's where you see all the other things that nurses are absorbing because of the challenges that we're having with recruiting and retaining ancillary staff. And then the other bucket, right, in terms of other things that nurses could be doing that's taking them away from patient care. This is another data point that we're finding is sliding in the wrong direction over time. And we've been looking at this for some time now in terms of the organizational support perception from nurses. And you see it's more broken out in a third and a third and a third, where nurses don't necessarily feel good about their organization, valuing their contributions to its well-being, taking pride in their accomplishments at work. Organization would notice if they did the best job possible. Organization really cares about your well-being, and my organization really responds to my complaints. So this is where we really have to do a lot more work. We really have to really understand how organizational support is perceived, because when you talk to leaders, they'll say, I'm listening, I'm here, my door is always open. Nurses will say, but I'm telling you about my issues, and yes, you're hearing me, but when I come back to work my next shift, the same issues are there. Someone very wise told me years ago that a nurse is as good as their last shift. It's not about the pizza party or the tote bag that I gave them the day before, but if their last shift was less than satisfactory, all those other things don't matter. So that's why this slide is very important to understand. In terms of delegation, we also were able to understand from the survey that nurses felt that there are other things to be delegated more.
Sorry about that.
The other things that can be delegated more, one being medication preparation, and this includes medication administration too. And medication preparation, taking that administration aside, is also a piece about how, you know, to extend shelf life, a number of pharmacies have broken up a lot of the components for a lot of on the ground real-time mixing and putting together components. So that's what's addressed in that bucket, and that's what stood out over all the other things. But also drawing labs is another piece. And we know about IV therapy teams and how sometimes they're there for day shift and not for night shift. They're there on weekdays and not weekends. And this is a major component that's impacting nurses as well. Toileting, that goes to the ancillary support piece that I mentioned earlier, procedural support, and the list goes on and on and on. And you see how with the ancillary piece, a lot more nurses are doing equipment work, doing transport, doing patient intake, and also managing their assignments and distributing information where you don't have unit secretary, and they're having to do a lot of that work on the back end as well. This is the slide about tech enablement. We asked about what nurses felt in terms of what could be more tech enabled. I think I hit one too many buttons, so bear with me. I have a delay on my end. But we asked about what could be better tech enabled for us to improve our environments. And nurses said, number one, improve how we use documentation. Oh, I hit too many arrows again. I have a delay. So documentation, I mentioned that earlier, and I'm not going to belabor the point, but we have to really look at how our documentation systems are not working for us and see how we can make them work. Look at how we can get some support in terms of being able to understand how to contact people, how to gather supplies. You saw the example at Christiana Care, and I'm not suggesting everyone get a robot because some organizations cannot afford it, but how can we shore up these systems and structures to help nurses be more connected with their patients and take less time away from their patients? Medication administration shows up here again. I started my career in that era where we had a medication cart that would go door to door. Now we have stationary machines that causes a lot of nurses to walk back and forth all day long. So how we can help with some of that technology to make it more mobile is where we have some opportunities. Nursing handoff, and the list goes on and on. Please put in the chat if any of this surprises you. It didn't surprise me when I saw it, but I think it's really important for us to go back to some of the basics for us to improve the nursing work environment. But the key takeaway here is that nurses desire to spend less time on documentation, hunting and gathering, and administrative and support tasks. No surprise there. So when you talk about managing the nursing workload, and we're spending a lot more time here because, as Kiersten mentioned earlier, this is less about, you know, the sign we put up on how many people we put together and who we put together in teams. It's really about how we look at the components of care delivery, the people that make up the systems, the sum parts. So when we look at our data and really understand what the data is telling us, it's really saying that if we do this right, and if we do some of the minimal things that we can do to reduce nurses' workload, we can achieve some net time savings. And this is not to say that we're going to pull nurses away from the bedside. This could be reinvested in providing more care and time with our patients. A lot of us have been patients too, and not just for us, but also with our loved ones. And we've seen it, where in a number of cases, our nurses and people that are supposed to be caring for us are more connected with their technology than they are with their actual patients and with us as patients. The other piece is about delegation, and there's more data that came out in a follow-up survey that we did about how there's a divide between what nurses feel they do well and nurses feel that they delegate well, but when you talk to people that delegate to, they don't feel that. So how we can improve delegation, not just to say you know who to talk to, but how you engage them to help with reducing our workload. So we'll share that resource with you as well. So redesigning care delivery models and really is really about adjusting how we have nurses spend their time. It's less about how many people we have on the team and who we put on the team, even though that's important too. But the key thing that we need to take away from this is that performing below top of license and non-value added activities does create inefficiencies, and it leads to high costs and nurse dissatisfaction. We also know that nurses are telling us that they'll like to spend less time on certain things, and they'll like to really look at how we can do more and proper delegation and how we can really leverage technology to work for us. And the key takeaway there also is the fact that some of the technologies that nurses are looking for are there in the system that they work for, but they're available to some groups and not available to others. So how can we spread the love to make sure that all nurses and everyone, physicians and nurses, can have the same technologies available to them to help us be better for our patients? I don't know what's going, okay, here we go. So we know that this is not an overnight fix. The two change is going to require a number of investments operationally and culturally. I see in the chat, there was a question about costs and expense. You're right. This is a very difficult time because a lot of organizations are tightening their belts because they're seeing their margins decrease. In reimbursement or revenue reimbursements not necessarily increasing. There's no inflation factors anymore when it comes to reimbursement. So how can we look at, again, how we can do things differently for us to meet the broader goal, right? For us to have an environment that is healthy, and not everything requires technology, but it's really about how we can have nurses at the table to revisit and revise care delivery models. We just saw your data. 66% of you feel your care delivery models can be changed. The other part of that question is, how involved are you in making those changes, to sit and have a brainstorming session to really look at how we can reinvent our care delivery models and have something that we can study? So another piece of this, which is a broader concern, is that we feel that there is a concern about there being a resistance, some resistance to change. I think we have another poll question. Is this where we place this poll question? I want to make sure I'm not skipping over that because we have another poll question for you about change. So tell us. Thank you, Nicole. There are numerous studies that indicates that healthcare organizations struggle with implementing change. So which group do you feel is most resistant to change? We'll love your thoughts on this. So click away. Let's see what you think. I'm curious. And I know someone asked earlier about organizational barriers, and that comes in a number of different ways in terms of policies. It could be people. There are a number of things that prevent a number of things from changing. C-suite are people who have C's in their titles, right? Like chief, fill in the blank, chief nurse, chief financial officer, your chief operating officer, that's the C-suite. So Sandra, I hope I answered your question. And leadership are your nursing leaders, like managers and directors, supervisors. That's what falls in the leadership category. And then you can say all the above. Thank you, Alex. Oh, well, you had to put in the dollar signs about your C people. That's very funny, but true. Hopefully you're filling out the survey. Because we do have data that indicates that there is a lot of resistance to change. And what you see behind the survey is that it's broken out in a third, a third, a third. But we want to know from you, who is behind these numbers? So should we close the survey? See what the results are. Oh, look at that. You know, from this, I say it's kind of split, but yeah, nurses 28%, leadership 19%, C-suite 15%, all the above. So for the most part, again, this goes to that system piece. There's a belief all around that there are concerns or there's an unwillingness to change or resistance to change. And that comes with some fear of trying something new. And it's not like, you know, using the car analogy, when our car is not working or things are not going well with, and we hear a little funny noise with our car, we put in the shop for a couple of days and figure out an alternative and pick it up when it's ready. In this case, you're not closing the ED and you're not closing your front door, and you're still going to get patients. So how do you get to making these changes that need to be made clearly for us to be better for our patients? So I do understand some of the resistance and the challenges there. But you see here from this graph how it's broken out. And we have more data with another study that came out that indicated that a lot of nurse leaders are resistant to change or have neutrality to change. So why is that? And is there something that needs to be done to break through? Because this is not sustainable, right? I read an article about how we, in nursing and with the staffing crisis, we have to fix this hot mess. People feel that this is a hot mess. And how do we get to addressing a lot of these challenges? So factors that impact models of care delivery that we have to consider when we're looking at innovation are all that you see here. And some things sit outside and some things are within our institutions, as you can see. We talked about EHRs, nurse well-being, equipment issues, ancillary support, nursing workload. All those things roll up to care delivery, but then there are the outside impacts too, right? In terms of technology, determinants of health, payment, regulation. And then we try to impact nurse-sensitive indicators with everything that we do, patient experience and patient outcomes. We cannot achieve patient outcomes at the expense of our nurses and their well-being as well. Both go hand in hand, right? A healthy nurse, healthy nurses equate to a healthy system where patients are receiving care. So as to serve for some inspiration as I close and we go to Q&A, because I know there are a lot of questions in the chat. I'd like to introduce you to a boy in Kenya called Richard. And this is a great YouTube video that I highly recommend called Making Peace with Lions. And Richard decided, because of him and his responsibility where he had to guard the livestock for his family in Kenya at the ripe age of 11, he was struggling because lions will always come and devour some of their prized livestock. There was a bull that they had, which was their only bull. And they woke up one morning and this bull was killed by a lion, half eaten by a lion. And people around, and the Maasai people and people around would always kill lions, but he struggled with that because in their religious beliefs, they believe that everything comes from heaven and every God's creature deserves a chance. So there was a conflict where I'm killing lions, but we should believe that, you know, lions are God's creatures. So what do I do? So he came up with, he tried a number of different things. He used fire at the first time to walk around the pasture to guard his livestock, but the lions then knew where he was, so they always came around the other side where he wasn't and devoured the livestock on the other side. And then he used a scarecrow, and they saw that the scarecrow wasn't moving, so they'll just kill livestock around the scarecrow. And then one day he couldn't sleep at night, and he walked around with a flashlight. And that night, for a few hours, and that night, the next morning when he woke up, he saw that, you know, he didn't lose any livestock. So he used that thinking to apply it to taking apart his mother's radio, connecting wires to batteries, and put these lights his livestock, where he never lost anyone or any of his animals to lions. And then he set it up where he told everyone about it, and it became a best practice around where he lived. And he was able to do a TED Talk on it. So in a nutshell, with what we're dealing with here, with what I showed on the previous slide, we have a lot of lions that we have to contend with in healthcare. And when you think about what Richard did and what he took to mind, or what considered in thinking about his new way of managing his livestock, he changed his thinking and mindset about his enemy, which was his lion, because he said, I used to hate lions, but I've learned that I don't have to hate them, but I need to create a solution around them to protect what was important to me. He thought about a number of methods to address this problem. I told you about fire, scarecrow, and then blinking lights. He went through a lot of trial and error as well. He also looked at how we kept his enemy in mind. So he thought about the lion and coming up with the solutions. He took on calculated risk by dismantling his mother's prized possession, her radio. And he jokingly said that she almost killed me when she found that I took her radio apart. And he came up with an innovative solution that worked for not only himself, but for his community. And he told people about it. He spread the word. And that's what we need to do more of in nursing. And scaling up to what I mentioned earlier is very important, because we don't have to keep our own best kept secrets. We're all in this together, and we need to think about how we can partner for us to be better together. So key takeaways for us to do some innovation in care delivery. One, we have to modernize care delivery models to ensure that they're inclusive, evidence-informed, and technologically advanced. We should also establish innovation in care delivery models as a strategic priority. It should be on strategic plans for every institution to invest and support and have nurses at the table to reinvent. And we also need to make sure with whatever we create, we're reducing physical workload and cognitive workload to prioritize high patient care and also incentivize de-implementation, because we have a lot of non-value added tasks that we do. And that's where we get to the good middle that we're trying to get to, where we're getting to high value and we do feel satisfied and we find meaning in what we do and take away some of the high burdens of what we've been tasked with. And at times we have to also say no, which is a principle of essentialism, because there's so many things that we say yes to, where we become the sponge. And then it turns out that after a while, and then we decide that this is not working for us anymore. We need to either think about a solution that's not the best in terms of leaving healthcare altogether or nursing, which we don't want for you. So we'll close here with our presentation with saying that we have a lot of work to do. There's a lot that has been put in your lap in terms of what has to be done. But this is by no means is indicating that we're not doing beautiful things. Our work is unfinished. It may be discolored. There may be vegetation growing on some flooring that should be tiled by now. But the key thing is that what we're doing is accretive in nature. We're building over time. So this is not to take away from anything that we're doing so far. We just need to continue to build and be undeterred and undaunted to get on the other side. And even if we don't get to see the results and the fruit of what we are doing to make it better during our time as nurses, we set it up for those that come after us. So that's what I want to take away. We do beautiful things with patients at the best and the worst times of their lives. But at the same time, we have to do better for ourselves and for our patients with reinnovation. So I think this is where we get to our Q&A. Leaving a legacy. Thank you, Paige. That's great.
Well, thank you, Dr. Boston-Leary and Dr. Henry, for your presentation. Let's take a few minutes to give our presenters the opportunity to answer some of the questions from the chat. I will ask our chat moderator, Rashida, if you could please share any questions from the chat.
Yes, hello everyone. I'll start by saying that Venice Bowen dropped in the chat that was a wonderful connection to nursing. That was a great analogy. I'm speaking about the ending of Dr. Boston-Leary's presentation and Dr. Henry's presentation. So lots of great questions and discussions in the chat. Thanks everyone for your engagement and thoughts and ideas towards this important topic. I'll start with a question that was shared earlier on, and this is when Dr. Henry was speaking about innovative care delivery models. Carol Beeler added a question: is there more information or specifics on organizational barriers? That was one question, and the follow-up question was, is part of organizational barriers leadership resistance?
Dr. Boston-Leary, I might turf to you only because I know with your work and publishing, you may have some good insight into what else exists out there.
Yeah, so I would like to frame that as systemic barriers, right? You know, where there is an overarching belief that there's an unwillingness to change. There are policies that, and we know how long it takes for a policy to go through to get to approval. So once the policy is done, to get it revised, it's going to take about as much time or even more. So it's about the policies and the that are there that prevents change, or really is a perceived barrier for change. So I think there's a lot to unpack there, and I think that's a great question, because some of those barriers that are called organization barriers are real. Some of them are perceived, and we need to understand how accurate the perceived barriers are for these changes to occur for us to get on the other side. But this is where shared governance comes into play, or professional governance comes into play, right? Where we understand what these barriers are, why they are barriers, because for what we're trying to to achieve, right, in nursing, and what we're trying to achieve with our charge as nurses, with our social contract. Even though these may be barriers, it doesn't mean that they can't be broken through, right? It doesn't mean that you can't escalate them to say, why is this? You just think about some of the things that I remember very early in my time as a new leader in a new hospital. I asked the department, and I saw someone ask about OR. I'm an OR person. So I said, what's your biggest barrier right now? Tell me what it is, because let me see what I can do to help that. And they said, the laundry department folds sheets the wrong way for the OR tables. So we always have to redo the sheets. And, turnover time is important in ORs. So, and efficiency. So us having to redo these sheets whenever they come up from laundry adds time. So and we tried for years to get these sheets folded a different way, and no one folded them in the way that works in an elongated way that will work for our tables. All that took was a phone call. But in the minds of the team, they thought that it was going to take God and country to make that change. So very important to understand what are perceived versus actual barriers. Let's deal with the perceptions and then get to the actuals. Understand what's high impact, low effort, and deal with those. And then we get to the harder stuff that we have to deal with. So that's how I answer that question. I know that was a bit of a country ride, so I apologize.
Thank you. Thank you. Our second question, still under the umbrella of innovative care delivery, do you feel that telemedicine and other methods of virtual nursing methods of virtual nursing, that we are moving away from bedside nurses being task-oriented? For example, having an IV team to put in IVs and lines removes that skill from the floor nurses. So the question is, do you feel that telemedicine and other methods of virtual nursing removes nurses essentially being at the bedside and then being more task-oriented?
So I can take this one. And I'll share actually a personal reflection that speaking with, I'm in a 10 hospital system in critical care. I'm in a small community hospital, and talking to our director of critical care for the system recently, she was talking about leveraging telemedicine for us, as we're a sole APP, advanced practice provider, in the hospital at night for critical care. And I kind of initially, even though I embraced the idea of innovating, felt a little resistant to how is someone remote going to help me at night. But then when we talked about it, what she really talked about was partnering, so that, say a patient's having issues, they're decompensating, I'm in the room with that remote person also there doing the interface with a computer, with the documentation system, to look at labs, to order tests, to sort of handle the IT interface, so that I can be high touch with the patient and use my clinical assessment skills, have the conversation with the patient about what's going on. So I think it's back to that tribrid care delivery model. And when I reframed my thinking about it, I'm really excited to pilot this, because I think it will only help me provide more efficient care and spend more time with the patients. And I think with tribrid care delivery, we're really thinking about, optimizing that high touch care of the nurse at the bedside. And I think, not necessarily going back to that more sort of functional nursing, but optimizing the ability of the nurses at the bedside to provide that high touch care.
Yeah, that's so true, because you will never meet a nurse that will say, set up a system that will that will allow me to spend less time with my patients. Like, you will never hear that. And that is a great foundation to build on, to make things better for where we need to be, right? So that piece about high touch, we could never leave that behind, because that's part of our core.
Thank you. We have here, looks like one of our last questions. Just want to remind everyone, if you have any questions, now is the time to add it in the chat, or feel free to take yourself off of mute and ask it. So we have a question from Mercy Alexander. Is there a standard platform where this work regarding care delivery can be documented or can be shared?
Standard platform. Say that again, Rashida. I'm sorry.
Sure.
Trying to-
There is a standard platform where this work regarding care delivery can be shared. And Mercy, feel free to take your phone off of. I'm interpreting this. Is there a place where this information, lives and is shared for, organization to organization?
Yeah, if it's about what we've developed, go ahead, Kiersten, go ahead, because I don't know if it's about sharing this work, because it's readily available for everyone to be able to access it. But
I'm interpreting as sort of the next step, which is something that's being worked on by the core team, that really facilitated the task force and think tank, which is a platform in which people can engage, share best practices, and share those learnings and sort of continue to allow those things that have worked well to permeate. So I think it's still in the making, but my understanding is that that's the ultimate goal, is to have a place where this, the work that has been done is out there and available, and then to add to that with what others are doing and how they're implementing these things.
yeah, and I think the key thing is that we need to make sure there's data to support these new models. We know over time with the models that you saw on the screen that was on Kiersten's slide, earlier slides, there are a lot of models that have not been studied for years. We don't have any current data. Even when you look 10 years out, 8 years out, there's not enough data. So we have to do some work there. And with what we're seeing with a number of nurses now getting advanced degrees, what a great opportunity to have a number of nurses that are pursuing these degrees as part of their coursework, dissertations, what have you, to do these types of studies. We have to have evidence behind some of these, because that is part of the resistance as well, where you don't have the results. So the automatic assumption is we're going to try it and we may not like it, and then we're going to invest all this whatever money, and there's an unwillingness to support it. So we need the evidence, and this is what we would like to make the call for any one of you, if you're trying new models, to make sure you have the data behind it to support it. You saw Sill's work at Providence, where he has his data. You see at Christiana Care, they have their data too. They knew what their measures of success was, and they made sure they did their baseline assessment and a post-implementation evaluation. We have to do more and publish as well.
Thank you. We have a question from Carol. Many times hospitals are implementing too many initiatives to make, quote, any of them stick. What is your opinion or experience on the volume and length of time that successful change implementation has been accomplished and sticks?
That's a great question. I don't know if
I'm going
there's,
to give you that one.
yeah, I don't know if there's a single evidence-based answer to that, but I think not only is it about what changes you're implementing, but it's about that, thoughtful kind of PDSA cycle of really understanding your problem and assessing potential solutions, and then implementing and determining, I think it depends on what it is that you're changing and what's a meaningful N of data to collect to determine if that change is effective. So, but I think one of the key tenets is we want rapid cycle innovation. We want to be innovative. We want to measure, but we also need to be looking at the problem and all the factors contributing, and not be trying to impact multiple things at a time. And as Katie said, taking those things that are high impact, that don't take a lot of time and energy, kind of the easy wins, not that anything is easy, but taking those things that you can change that don't take a lot of effort really helps to garner buy-in for those next changes, because people see that there's being impactful change made. So I think determining, really what is going to be a harder move, a harder lift, and what can we change quickly and work on those things and measure, and then work on the bigger changes.
Thank you. We have our last question here. We've had a couple of participants who want to know how they can actively participate in the task force. Looks like Judy Walker and another participant earlier on. Are there opportunities for participants to engage in this work?
So probably in a different way, but unfortunately the task force has been disbanded. We did our work. And we had two groups. We had the think tank that met in 22. Nicole mentioned that earlier. And then we had the task force that met in 23, 22 going into 23. We've sunsetted both groups because we wanted to be very, outcomes focused and not have a meeting that ran for years or, beyond what we had. So both of these groups are disbanded, even though we're bringing some of them back, as you can see, to do the Project Echo. It doesn't mean the work is done, but the goal for both groups was to publish and promote and disseminate our recommendations. We're doing a number of different things behind the scenes, working with AACN, and some of them are here that you see in the breakout groups. We have work we continue to do with AONL. I believe AONL is planning on posting, and I think this will go back to the question about the platform. AONL plans on posting a laundry list of all the different care delivery models that are out there. Now, a number of them don't have evidence behind them, but it still gives you something to look at and consider, so you're not working from a clean slate. HFMA is still a partner with the think tank work. IHI, Patricia McGaffigan is here. She's going to be one of the groups as well. So we continue to work with these groups in a number of different ways in an ad hoc way to see what else we can do. But the recommendations are available to you for you to take on and implement in your institutions. We are also working with a number of state workforce centers to implement some of the recommendations, most of them from the think tank work. So Hawaii is doing work and doing some statewide implementations. I know Maryland is thinking about doing the same. And I just heard that Illinois may be doing that too. And this is where there's economies of scale type of work that can be done to get us to addressing a lot of these issues. Because when you have all these separate entities working on the same thing, trying to recruit from the same pools, a number of these things are not taking hold. But there's some, it's that saying about power is in our cohesiveness. And there are groups that are doing statewide efforts in getting on the other side of this crisis. So that's where the money is. And I think that's where the opportunities lie for us to be better. So there are a number of things happening that we're paying attention to. We're also working with the CNIOs of the EHR companies to see what they can do to have a joint statement around what what could be done to make our documentation more efficient and make it work for nurses. And this is Epic, Cerner, Meditech, the big three, coming together on work to see what we can do for nurses collectively. And a number of things are afoot. So we're hoping also that there's work that's pending with the Joint Commission on staffing, and you hear about staffing further into the series, but there are a number of things that are afoot. So I'm saying that to say groups disbanded, so there's no group for you to be a part of in terms of the task force, but we're always reaching out to you to hear what we can do for us to help move the dial on a lot of the challenges that we continue to face.
Thank you, Dr. Boston-Leary and Dr. Henry. We will now transition from our Q&A to our breakout sessions. Before you are assigned to a group, we will review your discussion questions here briefly.
Now we're going to share one key takeaway from our discussion. First, we'll hear from Patricia's group.
Thank you, Nicole, and thank you to my breakout room. I wanted to suggest that probably the one thing that I could take from the comments as a summary point is the rapid succession of change and evolving roles that came out as we talked about LPNs, for example, who's involved in interdisciplinary rounds. And also when we think about some of the care settings and the complexity and needs of patients that arise. So I don't want to consume too much time, but I would probably float that rapid transition of staff, sometimes within the same organization and sometimes moving on to other organizations as they advance along their career paths, and some of the succession planning thinking that probably is becoming more important for us to think about very systematically and routinely. Thank you.
And next we have Dr. Boston-Leary's group.
Thank you, Nicole. So Rhonda, I'm going to invite Rhonda to talk about the model that she had shared. I know we had a lot of questions about it, but we'll love for her to share it in the main room here. But overall, discussions around, just some systemic barriers for change, some of the things that come up with leadership as well. There was a question about whether there are any magnet implications hiring LPNs, and I said it 3 times, and I've double checked this with my peers at ANCC. We do not have anything in the standards that prevents anyone from hiring LPNs, and we do have magnet standards, and we do have magnet conference coming up in a week and a half or maybe a week, and we do have organizations that are going to be there receiving their designation for the first time, and they have LPNs. So I just want to make that declaration now before I turn it over to Rhonda to talk about her model.
Hi, thank you for that invite. So I talked about a couple of things. One is a virtual nurse program that we're piloting on one of the units at my hospital. It's still in a pilot stage, so we don't have any outcomes yet. But we have a nurse from my unit that is the virtual nurse, along with some others. And she's very bright, very intelligent, but she broke her foot and can't come back to the work. So her brain still works, but she's not able to physically do the work at the bedside. So on that unit, they take essentially an iPad on wheels into the patient room. And then she has a conversation with the patient and the family. She does education on their disease process, on their medications. She goes over their discharge instructions, answers questions, and things like that. The other program I talked about, we have a program we call Patient Attendant Safety Aids, which is, or PASA for short, which we're using as a mobility team. They help turn our patients that need to be turned every 2 hours. They do passive range of motion on the patients. If they're able to, they get them up to a chair for meals. They walk them in the halls. And then we recently expanded or optimized their role by training them on how to do patient baths, how to feed patients, toilet them, groom them, and things like that. And the employees that we hire into that role are not required to have a college education. They just have to have a high school education and BLS. Typically, we have, on my unit, we have 30 beds, and we have 2 passes on day shift and 1 on night shift. So their ratio is anywhere from 10 to 15 patients each, up to the whole floor of 30 patients, depending on the shift. But we felt that was adequate and justified based on the fact that they're not walking them, getting them up for meals and things like that during the night.
Thank you for sharing, Rhonda. Next, we have Dr. Cassidy's group.
Yes, thanks, Nicole. So we had a really interesting conversation about how will all the great ideas that people come up with get disseminated. And I think that that's a really key point, is how do we improve dissemination and sharing? There were some actual examples given on improvements in care delivery, and they were centered around improving efficiency. One of which was adding a provider to triage so that the ball can get rolling before the patient is actually seen, so that it also frees up the staff so they're not having to put orders into computers and things like that. Another great example was a behavioral health team of skilled professionals in psychology that can be deployed. So when there are escalating situations happening, the staff does not have to be the ones trying to de-escalate. And there's been great improvements in workplace violence and that sort of thing.
That's wonderful to hear, Dr. Cassidy. Thank you.
You're welcome. Thank you to the group.
Next, we have Dr. Henry's group.
Thank you. I think a theme for our group that was pretty resounding was the team approach, but innovative ways to utilize that approach with really creating roles that allow nurses to bring their clinical expertise to support the nurse at the bedside. In addition, there was discussion of adding LPNs again, which seems to be a theme to a team-based approach that's had a lot of success. But a couple of examples were a clinical resource model where a clinical resource nurse is available, particularly on off shifts, to help support the nurse at the bedside with different skills, concerns, a second set of eyes for patient assessment, things like that. And another take on that was initiating virtual nursing to provide some of the skills that don't need that high touch portion of our patient care, like admission intake info, and helping with reinforcing discharge instructions, et cetera. So really some successful things with team-based care. The other thing was a wound nurse to support on a burn unit. So someone who's not in the staffing in terms of being assigned specific patients, but supports care of all those patients on the unit for dressing changes. And thank you again, everybody, for your amazing contributions.
And lastly, we have Cheryl Peterson's group.
Thank you, Nicole. In my group, we had a conversation about doing shift reports at the patient's bedside and how much they valued that as a change in patient care that they think is patients and families closer into the care of the patient themselves. There was also a conversation around throughput and this notion of it feels like there's a real heavy focus in this particular institution around moving patients in and out, and that created a real mixed feelings. Are we just pushing people out before they are ready to go or prepared to go? There was also a discussion around looking at hospital-acquired conditions or Cowdy, CLABSI, et cetera, and whether that created a singular focus as opposed to, particularly when there was like a monthly award, was there a real singular focus on these issues? And then we're not looking at the whole when we look at things like safety and quality. And then finally, we too had a discussion around team nursing and LPNs, but really from the focus of delegation and understanding, are we preparing our nurses to be able to delegate and understand what that means in a team-based setting?
Thank you.
Thank you.
As we wrap up today's session, there are just a few reminders I would like to share with you before we end for today. Don't forget to complete your evaluation form to claim your CNE credits. You could do so by following the link in the chat or scanning the QR code that's on the screen. You will earn 1.5 credits for today's session, and you can earn an additional 3 credits by attending our next 2 sessions. Our 4th session is on October 5th, and it will follow a slightly different style. We will have a panel discussion from task force members Zina Goncharo from ANA and Michelle Buck from the National Council of State Boards of Nursing. They will discuss the need for regulatory improvement, and the session will be moderated by Brian Sims, who is the Vice President of Quality and Equity at the Maryland Hospital Association. Thank you, everyone, for joining us today, and we hope that you enjoyed your time with us. We look forward to having you with us again next week.